name is Devin Crawford. I'm the center administrator here at the Rural Drug Addiction Research Center. And Rick Bevins, who's our center director, is out this week on a staycation. So I am happy to introduce Brendan Jacka. I hope I have that correct. Please correct me if I'm wrong.
No, all good. Thank you.
Perfect. He's a postdoctoral research associate at Brown's University Center for Epidemiology and Environmental Health. And he's a pilot project leader for the COBRA on opioids and overdose. That's one of our partner COBRAs here at the RDAR Center. And his project title is Trauma and Stressor-Related Disorders Among Layperson Opioid Overdose Responders. So I will let Brendan take it over. Thank you so much for joining us.
So I just wanted to express my thanks to RDAR team for inviting me to participate in this presentation. I did want to point out, obviously, I don't sound like I'm from even North America. I'm actually from Australia originally and spent 2 years in Montreal for a postdoc position, and have been at Brown University for the last 12 months. I was very lucky to team up with Dr. Brendan Marshall, who's at Brown University School of Public Health, who has an interest in overdose prevention and substance use. And early this year, I was promoted to a junior faculty position, which has allowed me to take on these, the COBRA pilot project. So I have both of my presentations in one section. So I'll do the first presentation that sets the mood for some of my work. And then, so only a few slides and then a few slides for my presentation. So please let me know if you want me to stop in between and we can discuss any particularities in the first section. So the first presentation is possibly slightly different to what's been shown previously, but it's largely qualitative ethnographic research. And the article's entitled, "It's Too Much, I'm Getting Really Tired of It. Overdose Response and Structural Vulnerabilities Among Harm Reduction Workers in Community Settings." This recently came out in the International Journal of Drug Policy and is based in Canada. So I just wanted to give you a quick little background about structural violence, structural vulnerability. My background is actually in laboratory science. So I understand that there may be some people in this seminar that don't understand some of the language. So I just wanted to draw your attention to the figure on the left, which is structural violence or social injustice, we call it. And if you look on the left figure, actually on the right of the left figure, we often think about individual processes affecting health and equity, when in reality, individual processes are largely affected by neighborhood and individual social position. And if we look further back than that, structural violence, or this kind of racism, social class, heteronormativity, criminalization of substance use, these larger structural factors affect the individual and the community and the individual processes. So it's really the idea of structural violence is what is society doing to an individual that affects their behaviors? And then it's not just about how it affects their behaviors, but it's about how society interacts with them. As a quick example, if you think of a person in supported housing that gets arrested for drug possession, they may be evicted from their accommodation. If it is the child of, say, a sheriff or a judge, they probably won't get evicted and they may never be charged. And that is just a really quick way to say, what is a person's place in society and what is society doing to them that affects their health? So that's the structural violence component. If we look at overdose education and Naloxone, we know it works. It's worked for 30 years in North America and Europe. It relies on people who use drugs to provide and intervene in their community, and they're effective at reversing overdoses, but it doesn't prevent overdoses in the first place. So it only happens once an overdose, it's only effective once an overdose, what has happened. So this study is looking at overdose prevention services in Toronto, Canada. So it's kind of a unique project. So Toronto has about nearly 3 million people compared to all of Nebraska's 2 million people. They had 300 overdoses in the city in 2018 compared opioid-related overdoses compared to the 60 odd that occurred in all of Nebraska. So the rates of overdose are much, much higher. So what they did is they said, how about we put harm reduction in the houses of people who use drugs? So they selected a number of people who use drugs and said, we will give you this equipment and you can give it to other people in your community, people that may not be able to access harm services for whatever reason. On top of that, the worker was given permission to allow people to use drugs in their house if they choose. So they may have family that they provide equipment to and the family can use the drugs there. They may not allow other people because they don't know them or there are other concerns. So it's really up to the worker to decide what happens in their house. The research here was looking at putting an ethnographer, putting like a qualitative researcher into the sites to observe what's happening. So this researcher went and sat in the room while it was working at the acceptance of the staff and the clients. They also did some interviews before and after. So this is just a really quick overview. So the findings from this research is that the clients are given a position of safety and security where they can use drugs in a world of overdose that's concerning. So, but it's stressful for the staff member and it's concerning about security of their housing if an overdose occurs. Similarly, naloxone is super helpful, but it doesn't mitigate the stress of responding to overdoses. So you still have frequent overdoses and it's still concerning, but so naloxone helps, but it's not necessarily preventing the problem. There's also fear from individuals that calling for assistance is going to increase problems with police. So we know that Good Samaritan law protects against overdose-related arrests, but it may not prevent other negative outcomes such as housing issues. And also having police arrive at your door may lead neighbours to complain or may lead to other eviction action. And when we have a look at this kind of structural idea, what is society doing to affect people? The main outcomes from this study was saying like legalized supervised injecting consumption sites would remove the burden that are placed on the workers. That these services would not prevent overdoses, but they would have somebody there when it happens and probably someone that's more supported. The major changes that change structure of society is to say, let's legalize it, provide a safe supply to people so that the risk of overdose is not going to occur. So essentially the takeaway messages from this study is that we've moved the responsibility from society onto individuals who use drugs. They're often not supported and it's a stressful environment. Naloxone is helpful, but it only addresses an overdose event, not the causes of overdose. And as I said, so decriminalization and safe supply are really what's needed to eliminate the risk of overdose. So I think that's my 5-minute presentation. Is there any, did we want to go with questions now generally or?
I'm just popping in here. Hi everyone, I'm Callie. We can definitely go ahead and do questions. Usually though, we save them for until you finish up the second short presentation. So
fantastic.
Perfect.
Great. So I can jump into that. So that's fantastic. So I hope that's given, I appreciate that, as I said, there's kind of difference in knowledge in terms of public health versus laboratory-based work. So that was just to give an idea of why I've gone into this project, which is looking at trauma and stressor disorders among layperson or non-professional overdose responders. So you may be used to the figure on the left, which is essentially the skyrocket in synthetic opioid overdose deaths, excluding methadone, in the last 5 years. What you may not recognize is the figure on the right, which is kind of an equal explosion in naloxone prescriptions that are available across the US. And so these are retail pharmacies. So it doesn't include harm reduction organizations that provide naloxone as well. So 500,000 prescriptions for naloxone were provided in metropolitan areas and they're tiny, tiny amounts in rural areas, which you would probably understand from rural Nebraska. So I just wanted to highlight, this is the transition of harm reduction from professionals to lay responders. This is the concern that we have from our work. So the rationale for PTSD among overdose responders is that about half of the US are exposed to the death or the illness of someone close to them. So it's the most common reason people are exposed to trauma. But only a subset of individuals would develop PTSD symptoms. For people that are exposed to family death or illness, it's about 5%. So only 1 in 20 people will develop PTSD symptoms based on the death or illness of a family member. For overdose, we know that fentanyl is much, much more rapid than other opioid-based overdoses, so heroin or prescription opioids. We know it's quick, it can be a few minutes, and it's potentially quite traumatizing. As I've mentioned previously, and I kind of hammer it home, we're tasking family and friends of people who use drugs with responding to this public health emergency. People who use drugs are commonly witnesses to fatal and non-fatal overdoses. In a study in Rhode Island and New England, about 80% of people who inject drugs have witnessed a non-fatal overdose, and 30% have witnessed a fatal overdose recently. So there's really is a lot of people seeing a lot of death and illness related to fentanyl in the community. Similarly, in Rhode Island, this last point is that the majority, about 60% of overdose deaths that involve EMS occur in the home. So this is our rationale, is we're saying that kind of like seeing a family and friend is sick or dying is traumatizing. Opioid is increasing overdose events. Community members are being tasked with responding to it. What is happening? So in the end, our study is aiming to demonstrate that we can recruit layperson opioid overdose responders, so that we can get family members, we can get people who use drugs, we can recruit just community members that have naloxone. So we want to demonstrate feasibility in recruitment in the first place in our pilot. And then the second aim is to examine the prevalence and correlates of trauma and trauma disorders in these people. So there's a lot of information on this slide, but essentially we're aiming to get 100 people who've responded to an overdose in the last 6 months that are not professionals. By responding, we say that they've called for medical assistance, administered naloxone, or performed rescue breaths. So essentially put their hands on a person who were heavily involved. Greater than 18 years of age, because we're asking some questions about their own substance use, understand English and consent for the study. We're also looking at whether we can expand this to include individuals who speak Spanish. The recruitment will use internet-based classifieds, so we've had a lot of success with Craigslist. We'll also use referrals from community-based organizations and some passive recruitment from community healthcare centers. We're very conscious of the facts that referral from community organizations will include people who are engaged with support. So we don't really want to just select people who are already going to harm reduction, because they may have social support that other people don't have. So we really want to make sure that we have a broad recruitment across the population. We have a couple of primary outcomes, or a couple of outcomes. The primary outcome is assessment of PTSD. So this is individual assessment of PTSD, not a clinical assessment. And the secondary outcome is acute stress disorder, which occurs within the first 6 months of exposure to trauma. If the trauma goes greater than 6 months or past the 6 months, then that is PTSD. And I just wanted to, before I finish up, there are other psychiatric comorbidities that we'll be assessing. So anxiety disorder, depressive disorder, panic disorder. We'll also look at past trauma history, and then also some events around the overdose, some characteristics of the overdose event, so where it occurred and who contributed to responding, and the history of the individual that's overdosed, and also the responder's substance use history. So essentially the plan is to start participant recruitment in late summer, early fall, over about a 6-month period, so to be complete in the middle of 2021. I'd like to acknowledge and extend my appreciation to the Co-Brown Opioids and Overdose, who are supporting this project, my mentor and colleagues at Brown University School of Public Health, and the Taylor investigators in Rhode Island. And that's it. Thank you very much.
Hopefully I am going to pronounce your last name correctly. So Stephen Kogut?
Exactly.
Yay! I always like when that happens. Let me turn on my video here.
Terrific.
Thank you so much for being with us. So Stephen is a professor of pharmacy practice at the University of Rhode Island's College of Pharmacy and is a pilot project leader for the co-brand Opioids and Overdose, who is one of our main partner co-brays. So the project title for this presentation is Buprenorphine with additional RX exposure for Beware. So I will let you take it away.
Sounds great. You can see my word cloud, just a little bit about myself. As Devin mentioned, I am a professor at the College of Pharmacy at the University of Rhode Island. I also work as a pharmacist, or have worked as a pharmacist for about 15 years at Butler Hospital in Providence, Rhode Island, a psychiatric hospital that has a drug inpatient and outpatient treatment program. So I've worked with lots of patients as well, and that has sort of inspired some of the research ideas that I'm going to present today. And you can see some other things in my word cloud. Medication adherence and polypharmacy have been areas of interest in my career. Health outcomes research is the group that I'm with at the College of Pharmacy. And we've been working with data from our state's prescription drug monitoring program, PDMP. And I'll talk a little bit more about that when I get into my study, which, as you can see here, is buprenorphine with additional RX exposure, or Beware, as the acronym says. So a little bit about buprenorphine for opioid use disorder. When I list buprenorphine here, I'm including buprenorphine, naloxone, and we know there are some indications for sole ingredient buprenorphine, but that's not really what I'm meaning. It's really just to identify the the important ingredient, and I haven't included naloxone in the description throughout, but that's what I mean. We're talking about Suboxone, et cetera, sublingual and tablet formulations of buprenorphine that predominantly include naloxone as well. But as many of you are probably aware, the availability of buprenorphine as a modality for treatment has really been a step forward in the treatment of opioid use disorder. It's promoted access whereby patients can receive medication from community pharmacies in quantities that are no more than just picking up a dose per day at a methadone clinic, for example. Important to note that buprenorphine naloxone is part of a comprehensive treatment plan. So just like maybe with statin use or medications for diabetes, lifestyle modifications and other aspects of treatment are equally important. So we shouldn't lose sight of the fact that a comprehensive treatment plan involves more than just the use of buprenorphine. And in fact, I think those other aspects of the treatment plan are quite influential with regard to persistence with medication therapy. Some of the challenges with buprenorphine therapy include unequal access to providers. There's still, at the pharmacy level, barriers to refilling and prescription drug coverage. Some of this has been mitigated through state policies, but still could be problematic for patients. And like all chronic therapies, adherence is a particular problem, and I'll show some data about that in a little bit. My research project is also examining polypharmacy, so the use of buprenorphine concomitantly with other prescribed opioids and other medications that can increase the risk of overdose and adverse outcomes, such as benzodiazepines and muscle relaxants, etc. And this figure here is actually not from the paper that I'm sharing, but published earlier in JAMA, that just shows the increase in the use of buprenorphine over the last decade or so in all age groups except for younger patients, which is a topic for a different talk. So the paper that I wanted to highlight as for this part is by Matthew Darbreeze, who's an epidemiologist with the Johns Hopkins School of Public Health. This was published in 2017, and the data are actually a bit older than that. The data are from 2010 to 2013. So despite that, the data are a bit dated. The data source was quite large. It included 38,000 patients and looked at their buprenorphine treatment experiences, examining in particular the prevalence of non-buprenorphine opiate use among individuals who had started treatment with buprenorphine, and looking at opioid use prior to, during, and after the first treatment episode.
Stephen, sorry to interrupt. I think
Please.
that on our end, we are not seeing the slides advance. So we're still seeing the main slide of the very first one. There we go.
Oh,
Perfect.
thanks.
Thank you so much.
So I'm just going to leave presentation mode, and I'll stick in this mode. And I think I can make it a little larger too, if that will help.
That looks great.
All
Thank
these
you.
foibles today, but that's good. I can be in solidarity with pals, and he won't feel alone in that. Okay, so there is the chart that I had mentioned. I want to keep things moving in the interest of time. So here's the paper that I was going to present. Again, an analysis of buprenorphine utilization concurrently with prescription opioids, and then also looking at subsequent opiate utilization after patients had failed to persist with buprenorphine. The methods for this paper were a retrospective analysis of a pretty large data set that sampled from, you see the states, the 11 states that are here, which are fairly representative of the United States. This was one of these large managed care commercial payer claims databases. Didn't necessarily represent Medicaid as extensively, but represents more than 65% of all prescriptions dispensed in the US. So a pretty robust data source for the analysis. And what they did was they looked at individuals that had started treatment with buprenorphine. So they looked for a period of, or a buprenorphine prescription that followed a period of 12 months without a buprenorphine prescription. So sort of defining an incident case in that way. And then looking at their future buprenorphine refills from pharmacies and identifying when a gap of 90 days occurred without any buprenorphine dispensings. And that was to represent, that represented a period of non-adherence or non-persistence. And then among these individuals, they examined opioid use, prescription opioid use in the following ways: the number of opioid prescriptions, the quantity dispensed, total day supply, and the morphine milligram equivalents that the patient received. So here again, you see is about 38,000 patients that were included in the sample, and average or median age of 42 years. You can see the representation in terms of payer type. 3/4 were third-party commercial insurance. My experience is that sometimes a lot of Medicaid managed care and Medicare gets misclassified as commercial insurance. And that's always a tricky thing to tease out. But nevertheless, most of these individuals were receiving their pharmacy benefit through some type of commercial insurance. The median number of prescribers was 1. So this wasn't for buprenorphine prescribers. There was constancy with respect to that. And then the length of the episode in days, essentially a median treatment period of 55 days before patients were identified as failing to persist with buprenorphine. And that equated to about a median of 3 prescriptions before a 90-day treatment gap was identified. So let's look at what they found. So during the first treatment episode, there were, well, let me first orient you to this table. The columns represent the period of time before the treatment episode with buprenorphine, during the treatment episode with buprenorphine, and then the 12 months after the patient had failed to persist with buprenorphine, and examined whether or not the patient received prescription opioids dispensed from a pharmacy during those periods. So for example, you can see that 24% of patients received a prescription opioid before their first buprenorphine prescription, and also received an opioid prescription other than buprenorphine after they had failed to persist with buprenorphine. And you can sort of infer from the different columns here that there was a substantial use of prescription opioid use both before and after, and that's presented visually in this figure, which I really like. The figure denotes first a pretty steep decline in adherence over time for new initiators of buprenorphine. So, by 3 months, for example, 2/3 of patients had failed to persist, and you can see, maybe the decline decelerates over time, but yet, much like other chronic diseases, we know that, long-term persistence is a challenge, and maybe particularly so in opioid use disorder. On the left side of this index line here, this vertical line, is the percentage of patients that had fills for non-buprenorphine opioid prescriptions prior to buprenorphine. And then looking after this time at the number or the percent of individuals who had an opioid prescription dispensed among those that had maintained buprenorphine adherence, which is this line here, which shows, I suppose, positively that as buprenorphine persistence was maintained, the use of non-buprenorphine opioid prescriptions declined, quite, down to 0. But yet, among people that had failed to persist with buprenorphine, you see prescription opioid use increasing up, and not quite to the scale where it was before buprenorphine use. But so I guess the message is, well, I've got a slide about the message, is that this paper reveals in an analysis of a lot of individuals who had started treatment with buprenorphine, 38,000 of them, adherence was very suboptimal, and there was a high use of prescription opioids both during the buprenorphine episode and after the buprenorphine episode. So it's 43% of patients that had a dispensing for an opioid. These aren't necessarily patients that are chronically using other prescription opioids. An individual could have had 4 days supply of a tramadol prescription for an acute injury or something of that nature. But nevertheless, they identified an opioid prescription in 43% of patients, and 2/3 of patients receiving opioid fills after they had discontinued using buprenorphine. Some of the limitations of this study: the data were older. We're only looking at prescription drug use, no information on the medical side. Methadone use isn't captured, so many of the folks that didn't persist with buprenorphine may in fact have switched to treatment with methadone. And as I mentioned, potentially Medicaid is underrepresented, so I wouldn't necessarily say this is generalizable to all payers. And I'll try and make sure I leave Pal some time. So I'll go through my COBRA study in just a few minutes here to let you know where it picks up from what I just discussed. So I'm going to skip this slide, which speaks to concurrent use of opioids and other controlled substances with buprenorphine, and mentions a drug safety communication that notes that the concurrent use of benzodiazepines should not be a contraindication to medication for opioid use disorder. And so there's risks that need to be mitigated, but hopefully don't exist as a barrier to effective treatment. But here's my study. I'll be looking at rates of concurrent use of buprenorphine and other prescription opioids, benzodiazepines, sedative hypnotic drugs like Ambien and Lunesta, and other CNS depressant medications. You might be familiar with the FDA advisory that noted the risk of benzodiazepines in combination with opioids in terms of overdose fatality. But that alert also included non-benzodiazepine controlled substances as well. So that's why we're going to be looking at those categories as well. And then I'll be measuring adherence in much of the same way that they measured it in, well, I have a slide to show how I'll be measuring it, but essentially looking to see if the concurrent use of buprenorphine and these other prescribed controlled substances is associated with adherence with buprenorphine in the acute phase. To do this, I'll be using data from the Rhode Island Prescription Drug Monitoring Program. The Department of Health in Rhode Island has very progressively made this database available to researchers. And, I'm very grateful for this. My colleagues certainly are as well. And I'll be using this data source and these particular variables in conducting this analysis. So there's information about prescriptions that are dispensed, and then some limited information about patient demographics and characteristics, similar to the characteristics that I presented in Table 1 for the Dalbry study. And here's how I'm going to measure adherence. We'll be looking at prevalent cases. In other words, all those individuals that are just have dispensings for buprenorphine, irrespective of whether it's a new start or not. And the idea here is to measure if people are using the medication constantly without gaps, and we don't want to see sporadic use, in other words. So these are pretty standard methodologies for calculating adherence patterns from pharmacy claims data that I'll be applying. So in one analysis, we'll be looking at what I've called prevalent cases and looking to see if there's sporadic use or consistent use of buprenorphine. And then we'll do an analysis to look at incident cases, so where there's a treatment period that doesn't, or a period that doesn't include buprenorphine, and then we have a new prescription for buprenorphine. Let's look at that first 90 days to see if patients persist with therapy or what their adherence is during this period. And then we'll be looking to see if adherence is associated with not only the concurrent use of other controlled substances, but the other characteristics that we mentioned here. And some other interesting angles that we're going to include: how much of the concurrent use of controlled substances and buprenorphine is attributed to the same prescriber? And is adherence with buprenorphine associated with particular prescribers? Is adherence better, for example, if you're receiving your medication from maybe a center of excellence or prescriber, one prescriber versus another? Does the quantity dispensed influence treatment adherence, etc.? Some future directions, I'll just leave this here in the interest of time. But certainly, as you might imagine, there's lots of implications for this sort of research and opportunities to have it inform, the areas that you see on this slide. And that's my talk.
So I'm going to turn it over to Paul's, also in the interest of time, so we can hear about his great work as well.
Hi, this is Palsamy Periyasamy, Assistant Professor in Department of Pharmacology and Experimental Neuroscience, UNMC. Actually, today I am going to present some basic science work and related publication. Today we will discuss about some epigenetics related work. I think most of you people are aware of it, I think. So this is some basic publication I am going to present to get some knowledge. Maybe coming seminar series, I will go in depth publication to discuss in detail. So the manuscript today I am going to discuss is the role of DNA methyl transferase in cocaine treatment as well as withdrawal in the nuclear accumbens of mice. Actually, coming to epigenetics, DNA methylation is one of the main mechanism. The other mechanism I will discuss later, including histone modifications and long non-coding RNA. I mean the non-coding RNAs, they all involved in the epigenetic mechanism. So, Kelly, can you go for the next slide? Next slide. Yeah. So, okay, we know that cocaine is one of the psychostimulants causing neuroinflammation by changing the neuronal structure, function, as well as acting the glial cells such as microglia and astrocytes. It is well known that cocaine affects several brain regions, including nuclear accumbens. This region is mainly implicated in the reward function as well as drug addiction. As I informed earlier, DNA epigenetics plays critical role, and DNA methylation is one of the phenomena involved in the epigenetic modifications. So this DNA methylation involved in the lot of changes, including long-term behavioral changes. In this manuscript, the authors determined the role of DNA methyl transferase 3A how it involved in the epigenetic regulation of cocaine treatment and with Rhode. Next slide. So overall cocaine implication on neuroinflammation is that cocaine, Kelly, can I go? Yeah. Cocaine induces neuroinflammation by activating several neuroinflammatory cascades as well as inflammasomes. Thereby, it produces a lot of pro-inflammatory cytokines, chemokines. Thereby, it causes neuronal damage or dysfunction. As well as it activates microglia, astrocytes, and also involved in the BBB breakdown, leading to cellular infiltration. This is the overall view of cocaine and how it involved in the neuroinflammation. Next slide. Okay, so what are epigenetic regulation? Epigenetic regulations are three types. One is DNA methylation, that is addition of methyl group in the DNA molecule. Another one is histone modification, that is addition of some chemical groups, chemical moieties such as acetyl group or methyl group to the histone proteins. So first one is in the DNA, the second one is in the histone, as well as non-coding RNA such as microRNA, lncRNA also involved in the process. So these all three modifications mainly regulates the gene expression, whether it will activate the gene expression or as well as repress the gene expression. The next slide. So these slides shows the overall view how the drug of abuse alters the cellular function as well as gene function by epigenetic means. At cellular level, it activates the pro-inflammatory cytokines and chemokines. In the histone level, it increases the acetylation of histone 3 protein, histone 4, as well as it increases the activity of histone deacetylase 1, 2, as well as their recruitment. Thereby, it increases the acetylation of histone proteins and relaxes the chromatin. Then it leads to overexpression of that particular gene. So the histone acetylation also specific one based on some histone acetylation increases the gene expression, some of them decreases the gene expression. And another one is DNA level, that is called DNA methylation, that is mediated by DNMTs as well as MECP2 protein. So next slide. So my study mainly focusing on the promoter DNA methylation. So as I told you earlier, the enzyme DNMT, that is DNA methyl transferase, adding the methyl group to the cytosine molecule of the DNA, thereby it causes 5-methyl cytosine. So the presence of 5-methyl cytosine in the promoter region of the gene looks like a bumps on the road. So if we have bumps on the road, you cannot go fast. Similarly, the promoter region is methylated. The transcriptional binding proteins and other elements cannot bind on the promoter region. So it significantly affects the expression of that particular gene. So consider if you have a lot of bumps on the road, you cannot drive fast. So based on the bumps, you can drive. So if you have few bumps, you can slow down. If you have a lot of bumps, you cannot drive. Similarly, based on the methylation profile, the gene expression will be affected. So next slide. So the DNA methylation is carried out by three different enzymes: DNMT1, DNMT3A, DNMT3B. So the enzyme DNMT3A and 3B are involved in de novo methylation. That is, when seeing some external stimulus or environmental stress or whatever, these enzymes based on that stimulus add the methyl groups to the DNA molecules. That is called de novo methylation. But this methylation cannot be transferred to the second generation of the cell or second generation. So there, upon replication, the enzyme DNMT1 works on, that is called maintenance methylation. This DNMT1 selects the methylation, whether this methylation carried out by the DNMT3A or 3B is essential or not to carry further. So that is called maintenance methylation. So the DNMT1 selectively adds the methylation, or if the methylation is not needed, it won't carry to the next generation. So the DNMT is placed maintenance methylation. So next slide. So these are some overview about the epigenetics. We talked about what is epigenetics, what the types of epigenetics, and what are DNA methyltransferase, and the types, 3 types. So in this study, the authors interested in DNMT3A. So why they selected DNMT3A? Based on the paper published in Nature Neuroscience 2010, talking about DNMT3A regulates emotional behavior and spine plasticity in the nuclear accumbens. They selected this DNMT3A. If you see this expression of this DNMT is increased, the gene expression ultimately decreased. So the authors here, they designed this shRNA to block the expression of DNMT3A, and they validated the shRNA. This figure shows this DNMT3A siRNA linked with adenovirus. Linked with adenovirus shows specific downregulation of DNMT3A, not DNMT1 as well as DNMT3B. So this is the validation experiment for the knocking down. Then the next slide. So here the authors used 3 different of experiments. The experimental designs. One is the first one, they inject the siRNA of DNMT3A in the nuclear accumbens region of saline as well as cocaine animals. So first they inject the siRNA DNMT3B. Then after 4 weeks, they gave either cocaine or saline, 15 mg. Then after that, next slide, they checked the expression, locomotor activity as well as expression of DNMT3A. They found that knocking down of DNMT3A significantly increased the locomotor activity in CC group. However, the DNMT3A, this left panel shows the downregulation of DNMT3A, which means this enzyme activity is decreased by the siRNA, leads to expression of some genes. They didn't study the particular gene. Maybe the global gene expression is increased. As an outcome, the locomotor activity is increased. The next slide. In this second experimental design, they first inject the siRNA DNMT3A for, first they give the cocaine for 7 days. After that, they give the shRNA for DNMT3A, then they wait for 4 weeks. Then the 35th day, they give the cocaine challenge and they measure the activity of DNMT3A level as well as the locomotor activity. Next slide. So here you can see if you expose the animal with the cocaine, after that if you give the shRNA DNMT3B, they couldn't find any change in locomotor activity as well as the DNMT activity. So this indicates that once you expose to cocaine, after that even if you knock down the DNMT3A, it won't retrieve the effects of cocaine. So the cocaine effect is still there. Next slide. Here they did the alternate way. What here they did means first they give the cocaine injection for 7 days. After that they give the inhibitor, that is the RG108. This is the non-competitive DNMT inhibitor. For the 25th to 27th day, 3 days they gave. Then 28th day they determined the locomotor activity, and interestingly they found that, next slide, decreased activity of DNMT as well as the locomotor activity is significantly decreased upon RG18 treated cells. As well, overall, this study shows that, next slide. The key findings of this study is during induction of cocaine-induced behavioral sensitization, DNMT activities decreases. That negatively correlated with the behavioral sensitization, that is increased locomotor activity. Then they found that the DNMT activity decrease is mainly regulated by DNMT3A mRNA, and the cocaine withdrawal challenge dose-related behavioral effects are mainly associated with DNMT enzyme activity in the nuclear accumbens region. So, however, if you selectively inhibit the DNMT3A, it doesn't have any effect on the behavioral sensitization. However, non-selective inhibition of DNMT reduced the cocaine-induced sensitization. So this is the overall view of this study. So coming to my pilot project work, next slide. So here I plan to study the role of cocaine in microglial activation, and I proposed the signaling pathway, that is the DNMT1 lncRNA exist and P-bar gamma signaling axis. So DNMT1 is the DNA methylation enzyme, which is mainly involved in the maintenance methylation, and the lncRNA exist is the long non-coding RNA. So the recent days, these long non-coding RNAs has a significant effects on regulating the gene expression post transcriptionally, and P-bar gamma. This is the anti-inflammatory gene regulating the expression of several pro-inflammatory cytokines. So next slide. So long non-coding RNAs, they are the subgroup of non-coding RNAs. Their length is minimum 200 nucleotides, maximum several kbs. So there are 4 types of lncRNAs. One is intragenic, which means between the genes. Intronic means between the intron region and overlapping, and bidirectional lncRNAs. So in this study, we use lncRNA exist based on our array data. So next slide, please. So this is the first, before framing the hypothesis for this study, we did some preliminary experiment. First, what we did means we isolated the primary microglial cells and treated the cells with cocaine for 24 hours, 10 micromolar cocaine. After that, we isolated the RNA and we did the lncRNA array, and we found several lncRNAs. These lncRNAs mainly related to inflammation. And we found some of them are upregulated, some of them are downregulated, and some of them unchanged. But very interestingly, one lncRNA is significantly upregulated, that is lncRNA exist. We can see from right as well as left panel, the lncRNA exist is significantly increased. Then we did the literature search, we found that this lncRNA exist is expressed in many tissues, including brain, and is associated with nearly 12 disease classes and 50 diseases, including various neurological diseases. So we are interested to look at this lncRNA. Next slide, please. Then the protein PBAR gamma, that is peroxisome proliferator activated receptor gamma. This is the receptor protein mainly involved in anti-inflammatory signaling. So these P-bars has 3 isotypes. One is P-bar alpha, P-bar beta and delta, and P-bar gamma. So in this study, we focused on P-bar gamma because it is reported to have potent anti-inflammatory properties by modulating the NF-kappa B signaling. So there are several reports saying that this P-bar gamma is involved in regulating inflammatory response in macrophages, microglial cells, and several other cells. So here you can see the pro-inflammatory signal. We know that LPS that acts on the P-bar gamma, thereby it increases the pro-inflammatory mediators such as interleukin-1 beta, nitric oxide, TNF-alpha. So cocaine also known to act induce pro-inflammatory cytokines. Our lab published several articles on that. So based on this background, next slide, please. Yeah, also we treated the BB2 cells. This is mouse microglial cell line. Here we treated these cells with 10 micromolar cocaine for different time periods, 3 hours, 6 hours, 12 hours, 24 and 48 hours. And we isolated the protein and we did the Western blotting, and we found that time-dependent downregulation of this PBAR gamma protein, which indicates that this anti-inflammatory protein level is going down upon cocaine treatment, which indicates that the cells become pro-inflammatory. Next slide. Also, we already published that the exposure of microglial cells with cocaine increases DNMT1 protein, as well as in the mouse also we found the similar observation. Based on these three findings, one is LINC-RNA exist is significantly upregulated, PPAR gamma is significantly downregulated, and DNMT1 is significantly upregulated. We formed the hypothesis that, next slide, cocaine activates microglia, thereby increases inflammation by increasing the level of LINC-RNA exist and DNMT1. These LINC-RNA exist and DNMT1 regulates the methylation of PBAR gamma gene. So if the methylation of PBAR gamma promoter is increased, the transcription is ultimately decreased, leading to decreased expression of PBAR gamma leads to increased inflammation. I mean the increased production of pro-inflammatory cytokines. So the in vitro, here we are going to test this hypothesis using two aims. One is the in vitro part. Here we will use the mouse primary microglial cells and treated with cocaine, and we will elucidate the mechanism how the LINC-RNA exists and the DNMT1 form the complex with the PBAR gamma and alters the promoter methylation and decreases the protein, decreases the transcription as well as protein. In the specific aim2, we plan to do the in vivo work. Here we are going to inject the mice with cocaine 20 mg per kg daily for 7 days. After that, we will isolate the brain regions, mainly prefrontal cortex, hippocampus, and striatum. And we will check the expression pattern of these LINC-RNA exist, DNMT1 and PBAR gamma and inflammatory markers. So next slide. So the approach is the first aim, we want to identify the role of LINC-RNA exist and DNMT1, whether this LINC-RNA exist and DNMT1 forms the complex on the PBAR gamma promoter region. So for that, we will do RIP assay, that is RNA immunoprecipitation assay. So this will confirm this complex formation. Then we will check the promoter methylation status using bisulfite genomic DNA sequencing. From that, you can know whether the from that we can know the status of PBAR gamma promoter methylation. If the promoter methylation is increased, the expression of promoter, the expression of PBAR gamma is decreased. So this is the reciprocal regulation. And the third, we will check the expression of pro-inflammatory cytokines, interleukin-1 beta, interleukin-6, and microglial activation status by studying the expression level of IBA1, CD11B, and the signaling molecules DNMT1, PBAR gamma, and retinoid X receptor alpha, that is the co-receptor for PBAR gamma. So these all are the in vitro studies we plan to do. Then these studies will be validated in the in vivo. As I mentioned earlier, we will give the injection, cocaine injection for 1 week to mice. Then we will isolate the brain regions as well as we isolate the microglia. Then we do histological studies for the above said parameters. So next. So thank you for RDAR for giving this pilot project, as well as I would like to thank my mentor, Professor Silpa Buch, and our team members.
Thank you so much, Pals.
Yes.
Really, really appreciate it.